So, I will give you a short overview about sudden cardiac death, because that's why we do the screening, that's why we do the EKG, and it's very important that you know what sudden cardiac death means. It's a yearly incidence of 2 to 300,000 young athletes, and the older you get, the more sudden cardiac deaths you have. And the male are more affected than the female, as you know. We always need a trigger, which in football it's sports, activity, and we need an underlying substrate, which is a structural heart disease that you can obviously see doing an echocardiogram or an MRI, but sometimes you have an electrical heart disease that you cannot see. And it's why you have to do the EKG. And this is during an exercise test with a footballer, and he developed cardiac arrhythmia, ventricular fibrillation, and he had to be resuscitated. You know that most of the older patients, and I think we all belong into this group over 30 years, they suffer from coronary heart disease leading to sudden cardiac death. The younger ones, the footballers that we screen, in most of them we have hereditary cardiomyopathy or coronary anomalies, channelopathies, or other diseases. Things that are not inherited, you can see here, it's myocarditis or commotion or contusion cordis. So, Jerzy Dvorak already told you this morning that we do the pre-medical competition screening in the referees. You see us here 1 year before Brazil, and we just screened all the female referees a couple of weeks ago for the World Cup in Canada. Why do we do screening and how do we do screening? We use in Europe the Italian screening tools, so we do a patient's history, we do a clinical exam, and we always do an EKG. It's not implemented in the HHA screening from the United States, but we do it in Europe. We need 15 minutes. We also did a study on this. It costs less than 100 francs, which is also less than 100 euros and dollars. And the benefit is over 90% to detect patients or footballers that need a further screening. EKG screening started already in 2010 by Corrado. It was adapted, and the most recent ones are the Seattle criteria by Desno et al. They were published 2 years ago. And the Seattle criteria, they include like an ample system, EKG's criteria which are unrelated to regular exercise. They always need further evaluation. Normal findings that are training related, that do not need any further evaluation. And then we have this gray zone with findings that might need a further investigation. I show you the ones which are normal. All these EKG findings can be considered as normal in sportsmen. They do not need further evaluation. Sinus bradycardia, sinus arrhythmia, ectopial atrium rhythm, junction escape rhythms, first-degree AV block, second-degree AV blocks, etc. I will show you EKGs later on. What is very important is point number 10, the convex domed ST segment elevation combined with T-wave inversion in Black Africans. I will show you an EKG afterwards that cost me a lot of headache when I first saw it. Then you have the ones with abnormal findings. Some are related to primarily electrical disease, and some are related primarily to cardiomyopathies. Here you have, for example, ventricular pre-excitation, long QT intervals, short Q intervals, the Brugada syndrome. You also have, for example, suggestive for cardiomyopathies, T-wave inversions, complete left bundle branch blocks, left atrial enlargement, etc. I will not go through this list because it's not interesting for you to read everything, but I will show you now some EKGs which show some of these pathologies. And I want to ask you to vote whether you consider this EKG as normal or not. This is the first patient. do you consider this EKG norm? Oh, they gave me the wrong slides. They gave me the wrong slides. It should not be like that. You already see the result. Oh, this is not good. So what you see here, you see the ST segment elevation and the T negativation. And it's from V1 to V4. And this is exactly this black African pattern. This was a footballer that was screened 5 years ago. And this EKG criteria were not included already in the normal EKG criteria. So it gave me a lot of headache, and I did a lot of tests on the footballer, but he had a complete normal heart. So this is a normal EKG finding. Unfortunately, you will all have the results already, because can you not put the PowerPoint presentation, because this is the PDF of my presentation, because if I show you this, you already have all the solutions. No, it's not better. You have to think. Do we have it somewhere?
Unfortunately, we only received the PDF.
Yeah, but I gave it this morning. Okay,
it didn't reach us.
So you don't have to think, just enjoy. Here you see almost the same thing. You see a flat ST segment elevation and the T negativation. And if you look very close, you see here something, and this is not an artifact. It's this notch, and this is called an Epsilon wave. And whenever you see this, it's suggestive for arrhythmogenic right ventricular cardiomyopathy. It's a small difference between this EKG and the one that you had just before. It's only this ST segment elevation. You all know that arrhythmogenic right ventricular cardiomyopathy is the most common cause for sudden cardiac death in Italian athletes, and it's defined by replacement of the heart muscle by fibrous and fat, a thinning of the heart muscle, and the patient presents with this in our emergency wards with ventricular tachycardia, origin of the right ventricle, and this degenerates into ventricular fibrillation, and then you have to do resuscitation on the patient. Here is an autopsy specimen. This is the left ventricle, and here you see the right ventricle. No, you don't see it anymore because the muscle has disappeared and is replaced by fibrous and fat tissue. And here you see the histopathology with the fatty infiltration. This is the problem that you have to be aware of. This is normal T-wave inversion with the ST segment elevation, which is domed with the black African pattern, and this is abnormal if you have a flat ST segment and then T negativation. So you have to look very closely at your EKG. So you already have the solution. It's not fun. You have here an ST segment elevation in this football player. You have a J-point elevation, and this is called early repolarization. This is a normal finding. Some people think if a patient or a footballer comes with this EKG to the emergency ward and has chest pain, that he has coronary heart disease, an acute ischemia, but it's not, because it's in more than 2 leads. And you have classic definition of early repolarization with this ST segment elevation and J-point elevation, and sometimes you also see the J-point in the middle of the descending part of the QRS. The new definition is that you have also terminal QRS slurring or a very late J-wave already in the last part of the QRS complex. Now, the same footballer comes with chest pain, and then he shows this EKG. This happened once to a footballer that I screened. What you see here is, again, this ST segment elevation, but he also has PQ depression. So this is new to the previous EKG, and this patient has acute pericarditis. What do you do with this footballer? What do you tell him? Go do your match tomorrow? No. What do you tell him? Is he allowed to do sports? Does he need a break? Who gives him a break? Raise your hands. Okay. How long? 1 day, 2 days? 6 weeks. He needs a break of 6 weeks that his heart can heal. And then, so you have to convince him. Usually they don't do it. They just take the ibuprofen and they go on the next morning. So it needs a lot of energy to convince them to make the break. This is something that we see quite often, severe sinus bradycardia. This patient has 32, and this is a normal finding. So what is the limit where you say that it's normal bradycardia or it's too low? Where's the cutoff with bradycardia? 30. Under 30, the patient also needs further examination. This is a footballer that I screened 7 years ago, and his story is that he had a family history for sudden cardiac death. His mom died at the age of 35, but nobody knew why. And he had a couple of EKGs already in his life, and they were always considered as normal. They are not normal. What you see here is, if you have this enlargement, you see an isoelectric positive double notch of the T wave with a low amplitude of T wave. So this is not a U wave that you sometimes see at the end of the repolarization, which is normal, especially in young people, but this is a QT interval prolongation. And you also see here is QTC time is definitely too long with 3.9 milliseconds. So he has long QT syndrome type 2. Yes. I show you later in the next slide. So I had to exclude him from competitive sports because this is one of the channelopathies associated with sudden cardiac death. It's not only one long QT syndrome. Today we have 13 types, and the good news is that about 95% of patients have a QT 1, 2, or 3. And this one you also can distinguish on the surface EKG. Long QT type 1 has this broad T wave that mirrors in the middle. Long QT type 2 has the one that you have seen, this double notch and the low T wave amplitude. And long QT type 3 has a variable QT interval depending on the preceding RR interval. Short QT syndrome, so if there's a long QT syndrome, there must also be a short QT syndrome. This is a new entity. It's not known for 10 years, for a couple of years. And it's a very rare disease, but we also had a footballer presenting with short QT syndrome. This is defined by a short QT interval. This one was 290, and if it's less than 320, it's considered a short QT interval. And here you see the cutoffs for the long QT interval. It depends on the gender and also on the age. For male, it's over 470. For female, it's over 418. And if it's over 500 milliseconds, the patient has a high incidence of ventricular tachycardia. So he's very at risk for sudden cardiac death. It's the same. It's also genetic disorder, and they also have the same torsade de pointe tachycardia and ventricular fibrillation. It's completely the same thing. This is an EKG of the female referee screening that we did a couple of weeks ago. It's a young woman referee, and he has something that we see quite often. She has a P wave that goes into the wrong direction. It's not concordant with the T wave. So this is an ectopic atrial rhythm. It's completely normal. You don't have to do any further testings. What can happen to these people that they have atrial tachycardia? That can happen, originating from this ectopic focus in the atrium. This you also, the patient usually supports this quite well, and whenever you have this, you can do electrophysical study and do an ablation in case. But it's not a criteria for exclusion. Now you can, so you don't have the solution already. This is a footballer. He had also history of sudden cardiac death. And I would like you to interpret lead V2 of the chest leads. What do you see here? The first beats and the beat 3 and 4. Does it look normal? Looks somehow like a right bundle branch block. Somehow. But why does it change morphology? Does anybody has a clue what this could be? It's a Brugada. It's a Brugada type 3 and 2 EKG. A couple of months later, the same chap comes with this EKG. And this is the typical type 1 Brugada syndrome EKG. It's definitely a pathological finding. Brugada syndrome is also an inherited disease. It's usually caused by mutations in the cardiac sodium channel. And formerly, we had 3 types that were described in the literature, type 2 and 3, which is defined by the saddleback ST segment elevation, and the type 1 is defined by the cuffed ST segment elevation with the pre-terminal negative T wave. Also, this footballer you have to exclude from sports because it's an inherited disease. And I have to change rooms. Okay. So I thank you for attention. Only a couple of EKGs. 20 minutes is not enough to show you all exciting findings.